Thank you for the introduction. So I'm Harry Gebhard, orthopedic surgeon from Switzerland. I've spent 2 great years here with Roger 10 years ago, and let me say it's amazing looking back for 10 years and seeing this course at that time, how much it has changed and how important it is to really stay tuned. Disclosures, nothing relevant to the topics. So talking about virtual reality and looking also at options to learn endoscopy, for example, which is very cumbersome, I believe, the best is still to have a great mentor. And we've heard this today in a very nice talk, and Roger was privileged to be trained. And if this lasts for a long time, this is certainly the best you can get. But not everybody is as privileged to have a great mentor and to be able to keep up for many years. So in Switzerland, we look since a couple of years into aviation and working with jet pilots, because I think we can learn a lot to really have substantial keeping up like the knowledge and the training of pilots. I mean, who came with a plane here? Please, hands up. Would you like to fly with a pilot that never went to a simulator? Probably not, right? So there's a lot in common. It's a high responsibility between surgeons and pilots. It's complex procedures, teamwork, man-machine interaction, physical stress, emotional stress, and mental stress. Looking at our practice, we have like 30% all over documentation issues. We need to work on this. We need to respect the working hours more and more. It's over with 80, 90-hour weeks, at least for the residents. The surgeons' teams often lack required preparation and training. You have a high staff turnover, so anesthesiologists and nurses are going in and out all the time. We stay. And you also have to consider more and more family and private life, because life can be over quickly. So now looking at those two guys again, what helps if you don't have the mentor? It's like the 10,000-hour rule that everybody's aware of. You have to try, you fail, try again, fail, try again. Maybe you have success again. So this is what our life and our practice in education also later on encompasses. So this is jet pilots in Switzerland. And I want to ask you now, how quickly do you think those pilots get into a real plane and do this after doing this procedure in a simulator? It's under 20 hours, 20 to 50 hours, or more than 50 hours. Hands up for less than 20 hours. No one. 20 to 50 hours? More than 50 hours? All right, it's less than 20 hours. And why is this? Because they are in the simulator, and the simulators, of course, are very interactive. They give you feedback immediately, and they promote reflection. So this is the most important task that we also have in surgery, and principals learning those. So this is studies. There is like widely published literature out now by simulator training in surgery. And you look at the graph on the left, they do a laparoscopic procedure. You have young guys, you have like somewhat experienced guys, and you have very experienced guys doing the procedure. And they look over the time and how they succeed, like being better and better time-wise. So one thing you see is that the novices are doing much better very quickly. So this is like 10 attempts and 20 attempts compared to the first attempt. But what you also see is that the most important group, like the experienced ones, they also get better by doing simulated training. And now looking at studies and also now at the crowd here, not everybody needs to train early on, but we also need to be able to adapt what we do. And being here talking about navigation, MIS, robotics, endoscopy, there are a lot of people that are like 10 years out of practice, and then they all of a sudden want to adapt to a new technique. But how do you do that? If you are coming from this course, you're experienced, is this going to be your next patient on Monday? Do you really want to operate on the grandma or on the grandfather being your first patient after a 2-day course? No, of course not. Nobody wants to do that. So the WHO, we've heard that earlier today also, has looked in 2016 into complication rates in surgeries overall. And given 400 million surgeries, we have a complication rate from 10 to 20%, which is enormous. The mortality rate after surgery in Europe was 1 to 4% for all the reasons that are there. And now this is important. The preventability of complications would have been 40%. That's amazing. If we look now, which more and more gets important in the future, at costs, This meant an increase in hospital costs after complications of plus 119%. So that's no doubt we have to get better in preventing complications. So now I'm a part of the AO education task force, and what we do is we look at new technologies over the next years and what could be implemented in a really meaningful course curriculum. And now there are several techniques out. We've seen a lot of them amazingly presented here, and you can also try them over there. Looking on one side on fidelity, which means very low, going from real virtual to more real and realistic up to the OR. And then on the other side of mixed reality options, which means that we really then have to compare the techniques and put them in a cluster to see who can learn what from which technique in what setting. So that's what you then have to do. And I just want to give you now, as we've already heard about certain techniques and virtual reality applications, the certain steps that you have. So on the way here, you could now not read a book, but go into touch surgery, for example, and look on your iPhone or any other device how to prep an ACDF. And what you see is you see the steps that are important beforehand. It's not just incising at the right place, looking at the X-ray. It's also positioning the patient and doing all the important steps that make it a more successful surgery. And this is for the youngsters that have never done the procedure, maybe if they go to the course to be prepared well. So this is touch surgery as a first step into it, totally virtual. If you want to now go more into virtual reality using goggles, which you see on the left bottom, there is also a number of different companies looking at this. You have handhelds, as you see downstairs in the room, where you can have some haptics, but more importantly, you are in the OR. So we always talk about, can you feel the screw? Can you feel the K-wire? That's not important for the youngsters. For me, this is amazing. Taking out the spine of the body, walking around it, look where your needle is, or your Jamjidi needle is placed, and how to reposition it and do it again. Learn by failure. So this is already out for many operative procedures. You can take out the pelvis, you can take out the spine, and really look underneath it. And the needle that you see here is placed by yourself. So having this in mind, there is the next step, which goes also into more haptics now. You can see on a 3D screen using goggles, the patient underneath you, and then you have kind of engines, as Daidini has mentioned earlier today, and really have haptics. Like now you really feel how you fall through the bone, how you fall through, how it ends, how it gets soft. You have the haptics by those consoles. That's the next step. The next step you can also see downstairs is then to go from virtual reality into reality. So now you print your patient. You can use a device that's having X-ray, which is not X-ray actually, it's navigated instruments, but you will feel the same experience as you would in the real OR. So you have great bone, you can have different bone mixtures, you can even replicate your own patient, you can move the C-arm, and then you can also go to CT intraoperatively and see where your needle is, do injections and put in screws. Real spine you will extensively see in the lab. This is a simulator that also encompasses blood and soft tissue. It's a real experience in your OR. So I've did a couple of courses with them where you can train your people on a patient that has been printed by patients that really do exist. And you can use your instruments, your team, your OR, your microscope. So this is very close. The only thing you exchange to reality is the patient. You can also measure now nerve roots, for example, contusion and tension, and go out with measurable results and see if you're a rough surgeon or if you're a gentle surgeon. So this is getting better and better and gives you feedback. BrainLab presents some bridges now to the intraoperative setting where you can see the spine three-dimensionally, see your tumor, see your patient, and really walk around it. Augmetics we've seen with nice studies today, which is then a transfer also to have like the X-ray vision, let's say it like that. And I just want to like put on the way that you don't be the wolf that operates on the patients too early on. Get the simulation, get the training at whatever stage you are. because that's what we need to do. We need to be motivated. And this is the first chance now with all those techniques that we have the opportunity to really train and be measured. Thank you. Is there any questions?
Are you using this in Switzerland in any of the schools or education training programs to get residents and trainees up and running now?
Yes, so we do courses and we try to be open what's out there and then really adopt it and let them rate what they like.
So this is all adjunctive to sort of, do they start at a certain training level and they get a certain number of hours in? Do you have any ideas about what those hours need to be? You know, you're talking about 20 hours before you get in a fighter jet and fly, you know, Mach 2 and, $20 billion.
It's too early. It's too early. So we are right now just assessing the techniques and doing little surveys to find out what's applicable and what not and where it would fit in. So this is a very initial phase, but the aim would be to be like in 3 to 5 years up there to start a curriculum like that.
I think it's one thing to train on the perfect situation. A lot of surgeons can shine in the ideal situation, but it's really the complications and all these small things like knocking off a bone chip into the foramen and how you're going to get yourself out, these strategies to get out. Those are the real things that are difficult to get enough exposure to during training. You know, the vascular problem, the nerve problem, the dural tears, the extravasated nerve roots all over the place, the spinal cord. And, you know, how do we simulate all these situations, and which simulations are we going to do? How many reps do you have to get through those before you can be competent?
That's actually the perfect way to train that. For example, in the real spine model, you can do a dural leak and then suture it up without harming a patient. And there's also ways to do this with the virtual setting. So there's a lot of computing and CAS behind it. And what I think is that presenting this and also discussing this on the AO level, it's always the question like, okay, it's good, but come back 10 years later. But that's not the way, I think, because we need to work very closely and tell them like what we need, what the engineering should do, and that's the way to the aim. Because that's when it gets better. So looking at some of those techniques a year ago and looking at them a week ago, a lot of advancement have been made, but we need to be a part of it.
Yeah. Great, fantastic. Please.
So I know that you have been investigated many of these systems, at least 4, 5, 6 different companies are trying to do this kind of virtual reality simulation. When you look at all these systems, what do you think that for today, what is lacking? What is the measure that you don't have yet?
It's the courage. It's the courage of the surgeons to try it and to be open for it. The argument that always comes against it is it would never replicate the layers. It wouldn't be like reality. But now going into learning strategies, that's not what we need. Sometimes we just need to learn, remembering my first case when somebody said, now if assisted 200 times, do it. You are in charge. You need to guide your team. You need to guide the X-ray tech. You need to find the right instruments. You need to think about your last step and your next step and what you've prepared for this eventuality. So it's not drilling in the screw and how that feels. It's much more. You're the manager of the OR. So I think it's important to dissect it, as I said, in certain steps of learning, and then convince people that you can learn a lot also on a 2D or 3D VR station, which you would experience differently in a patient. And then have a curriculum in place where people are really adjusted to the stage they are. So that's, I think, like talking to people in auditoriums, that's the most difficult part, to convince people that that's a part of the future. We don't have enough exposure to patients to learn that.
Thank you.
Great. All right. Thank you, Dr. Gebhard.
Thank you.
Great.
I have one question. What do you think is the technique which has the most profit of that new technical advance, from the MIS techniques or from the scoliosis technique? Where do you think this is most helpful to apply?
It's different. It depends on the technique. For example, the midability simulator is good for all MIS procedures, obviously, because it's X-ray driven, and that's what again fits into those patterns. Yeah.
Of course.